Hello everyone, welcome back to MemoMap, and today we are continue with the respiration and we are focusing on gas exchange, but in this part we are going only to focus on three main points. First, how does gas exchange happen? Then the two components important to keep the oxygen, carbon dioxide level within normal range, and why this is important. So let's map it out. So, how does gas exchange actually occur? To understand this, we need first to learn about the partial pressures. The partial pressure for any gas depends on two main things: the total pressures of the mixtures and the concentration of the gas in these mixtures. Why the partial pressures is so important? Because the gases moves according to the partial pressure differences in a processes which is known as a diffusion, which mean gas move from area of high pressures to the area of the low pressures, and this also apply to the lung. So in the alveoli, the partial pressure of oxygen is higher than that of the venous blood, so the oxygen diffuse from the alveoli to the blood. Regarding the diffusion, there are certain factors that affecting the diffusion. So what determine how fast the gases diffuse? We have factors that directly proport to the diffusion and factor inversely proportion to the diffusion. The factor which are directly related to the diffusion, they are summarized as the BTSS PETs. And B stand for the pressure gradient, the T standing for the temperature, the S standing for the solubility, and the surface area. So starting with the pressure gradient, the bigger the difference in partial pressures, the faster the diffusion. For example, in oxygen, the pressure gradient is about 60, while for carbon dioxide it's only 6. This means that the oxygen much more faster than the carbon dioxide. And to increase the diffusion, this could occur by breathing pure oxygen or during exercise that increase the opening of the capillary. The second factor is the temperatures. As the temperatures increase, the gas molecule has more kinetic energy, so move faster, and this also increasing the diffusion rate. The third factor is the surface area. The larger the surface area, the greater is the diffusions, as occur during exercise by opening of more capillary, but the decrease in surface area as in the collapses will decrease the diffusions. And finally, the solubility, and this is where the carbon dioxide is the winner. The carbon dioxide is more soluble than the oxygen, so allow the pass through the respiratory more easy. Let's go to the factors that decrease the diffusion, or the factors which are inverse related to the diffusion. First is the membrane thickness. The thicker the membrane, the harder for the gas to cross it. So this occurs in pulmonary edema and fibrosis. The second is the molecular size. The larger the molecule, the more slow they pass or diffuse. So, what do you think? Who will win in the comparison, oxygen or carbon dioxide? Actually, the oxygen has a larger pressure gradients, but the carbon dioxide has the greatest solubility. They diffuse more efficiently through the respiratory membrane. Also, it has despite that it has a greater molecular weight, yet it still diffuse faster than the oxygens. So now, after we finish the diffusion, let's move to the second point in our topics for today's. So we learned that for gas exchange we need the diffusion, but the diffusion alone is not enough. We need to know that we have a perfusion and the ventilation. Both are two important components for diffusions to occur. So let's start with the perfusion. The lung has two circulation: the pulmonary circulation, which is responsible for the gases exchanges as it supply the alveoli, so that the oxygenated blood leave from the right ventricle through pulmonary artery, go to the alveoli capillary, take the oxygen, and release carbon dioxide, return to the left atrium, the oxygenated blood in pulmonary vein. And unlike the systematic circulation, this circulation has a low pressure and resistance. The second circulation is the bronchial circulation, and this circulation mainly supplies the bronchi and the pleura. It originates from the aorta and drains back to the pulmonary vein. So, here, before we leave the perfusion, important to remember two important concepts. Why don't our lung fill with fluid, or why our lung is kept dry? This is because the pulmonary capillary, the oncotic pressures in pulmonary capillary is more than the hydrostatic pressures, and the oncotic is responsible for reabsorption while the hydrostatic is filtration. So the net result is to keep the fluid inside the capillary and keeping the lung dry. The second is the physiological shunt. The shunts occur when some of the venous blood bypass the gases exchange, and it mixes the oxygenated with the deoxygenated, and this lowering the oxygen level in the arterial blood. How this occur? There are two classic examples for this. First, the bronchial vein and the coronary vein. Both of them actually mix the oxygenate with the deoxygenated blood. Since the bronchial vein, which containing the deoxygenated, go directly to the pulmonary vein, which carry the oxygenated blood, and the coronary vein, which carry the deoxygenated blood, go directly to the heart. So now let's talk about the ventilation. The ventilation is not distributed equally through the lung. Also, the perfusion. The perfusion is not equally distributed all through the lung. It's important to note that the base and the apex of the lung receiving a different perfusion. This is due to the gravity. While the apex has low arterial pressures, so the capillary collapses and blood flow decreases, the base has high arterial pressures and the blood flow is much more than the apex, and this is mainly due to the gravity. Regarding the ventilation, is the same. The ventilations differ between the apex and the base, and this is also due to the gravity. The apex has an intrapleural pressures more negative. This causes the alveoli to expand since it increases the transpulmonary expanding pressures, so the alveoli is already stretched. So during inspiration there is less ventilation since there is no room for more expanding. At the base, the alveoli is more smaller, and this is mainly due to the less negativity in the intrapleural, less transpulmonary pressures, and so during inspiration, the alveoli, which are ready for expanding, so the ventilation is greater in the base. Okay, so now let's put perfusion and ventilation together, and this gives us the ventilation perfusion ratios. The ventilation perfusion ratios here mean that for perfect gas exchanges, each ventilation should match each perfusion. So at the apex, both the ventilation and perfusions are reduced, but the perfusions decrease more than the ventilation, so the ventilation perfusions become less higher. more or less higher. At the base, both ventilation perfusion increase, but the perfusions increase more than ventilation, so the ventilation perfusion ratios become lower. When we look at the whole lung, the average ventilation perfusion ratio is about 0.8. So this is important since it keeps the arterial blood gases within normal ranges, which is 95 to 100 for oxygen and 40 for the carbon dioxide. So now, in this point, it's important to remember for the perfusion we talked about the two type of the circulation, the pulmonary and bronchi. Then we talked about the physiological shunt, and also we talked about the capillary is keeping the lung dry. Then we talked about the effect of the gravity on perfusion, which keep the pace with a higher perfusion, and also for the ventilation, the gravity is responsible for the more expanding of the basal lung. And then we discuss the ventilation perfusion ratios, and we said that post flow and ventilation become lower as we go from base to apex. However, the decrease in the flow is more than that of the ventilation in the apex, and this will leave the ventilation perfusion higher in the apex rather than the base. So we have high oxygen and low carbon dioxide in the apex if we compare it to the base. Let's move now to the second point, is why this is important, or what will happen if we mismatching the perfusion and ventilation. Now let's move to our final question for today, why the matching between the ventilation and perfusion is important. Because the ventilation perfusion ratios directly determine how much oxygen enters the blood, how much carbon dioxide leave. So under the normal average ventilation perfusion 0.8 means that every alveoli ventilated receive a good blood flow. So this will allow the efficient gas exchange. But what will happen if this balance is lost? So starting with the low ventilation perfusion ratio. If this occurs, the ventilation decrease while the perfusion remain normal. So as in the obstruction of the airway in the asthma, in this situation, the blood continue to flow through the alveoli, but there is no enough fresh air reaches. As a result, less oxygen enter to the blood and carbon dioxide will accumulate. In other words, the blood leaving this alveoli is more like the venous blood. So what about the high ventilation perfusion ratio? This occurs when the perfusions decrease while the ventilation remains relatively the same as in pulmonary embolisms. Here the air reaches to the alveoli but no blood available for gas exchange, and this will result in wasted ventilation. So this is, we call it the alveoli dead space. So the alveoli ventilate but cannot effectively exchange the gases. So normally ventilation perfusion is 0.8, perfusion ventilation were matched, but if the airway is obstructed, the ventilation 0 and the blood flow is continue, and this is a shunt. And the shunt will resulting in the lowering of the oxygen. But if the perfusion is the affected while the ventilation is almost normal, here in these conditions the air come but its gas not occur, so this is an alveoli dead spaces. So in the shunt, the oxygen is in the shunt, the oxygen in the alveoli, carbon dioxide in the alveoli is almost the same. The same, but is zero because there is no air entering to the alveoli, and the oxygen tension in the blood decreased. In the dead space, the alveoli and carbon dioxide is affected. The oxygen in the alveoli is higher, and the carbon dioxide tension is alveoli is almost zero, while there is no exchanging of or no blood passing into this alveoli. So, to compensate for this, it's important to remember that the alveoli hypoxia or the shunt, which resulting in lowering of oxygen, will result also in a vasoconstriction locally. So, due to the block of the alveoli, we block the blood, so redistributing the blood to more ventilated alveoli. As for the dead space, to regulate this, the hypocapnia will constrict the bronchi. So if we have a blocking on the blood vessel, the bronchi should be blocked, redistributing the air to the alveoli, which has a blood flow. Well, that's the end for our topic for today. Let's recap it all together. Before we finish, let's recap today MemoMap together. We started with the gas exchange and learned that diffusion is the main mechanism responsible for moving of the gases. And the factor affecting the diffusion are factors that directly proportion and increasing the diffusion when it increases, such as the pressure, temperature, surface area, solubility, and factor decrease the diffusion when it increases, such as the thickness of membrane and the size of molecule. Also comparing the oxygen carbon dioxide, also the oxygen have a large pressure gradient, yet the carbon dioxide diffuse more rapidly because of its solubility. Also, we learned that the diffusion depending on the ventilation and perfusion. We discussed the perfusion. We have two main circulations, the pulmonary, which carry the blood to the alveoli for exchange, and the bronchi circulation that supply the pleura and bronchiole. Important to remember that the pulmonary capillary keep the lung dry due to the high oncotic pressure compared to the hydrostatic. The bronchi circulation responsible for the physiological shunt because the bronchi vein drain which carry the deoxygenated empty to the pulmonary vein which carry the oxygenated, so this allows small amount of venous blood mixed with oxygenated blood, lowering little bit the level of the oxygen. We talked about the effect of the gravity in the ventilation and perfusion, and we said for the perfusion, the as we go to the base, the pressures increase and the flow increase. Also in the ventilation, as we go to the base, the ventilation increase, and this is mainly due to the less negativity of intrapleura with lowering the transpulmonary pressure when compared to the apex. So the alveoli in the base is smaller than the apex, so it is more able to expand during the inspiration. So it's important also to matching the ventilation and perfusion. So each ventilated alveoli should be perfused, and the normal ventilation perfusion should equal zero point 0.8. However, we have a regional variation in the ventilation perfusion, with the higher ventilation perfusion's apex compared to the base. And then we said that the mismatching of the ventilation perfusion ratios will result in the abnormality of the alveoli and the blood gases. Low ventilation perfusion as occur in the asthma or obstruction of the airway, where lowering the oxygen and increase the carbon dioxide. The high ventilation perfusion ratios as it occurred with the thrombus or emboli of blood vessels will cause a hypocapnia in the alveoli and increase of the oxygen in the alveoli. So to compensate for this, it's easy. Remember that the hypoxia with a low ventilation perfusion will cause a local constriction of the blood vessels, and so we redistribute the blood to the ventilated alveoli, and the hypocapnia with the high ventilation or the alveoli dead space were causing a block of the bronchi or a bronchoconstriction to redistribute the air to the perfused alveoli. So that's all. That's the complete memo map for gas exchange for today. See you in next episode.